Thank you, Tony, and good day to everybody. Pleasure to be here in place of Nick Corrine. As you've heard from Alexandre, as of March this year, the industry found itself grounded. And since then, we've been plunged into our biggest crisis ever. What became very clear at that point was that this was not going to be a quick restart operation. The restart effort was going to take a considerable amount of time. And IATA, as the industry's main trade association, moving to the next slide, we quickly realized that we needed to look at how to address the COVID risk throughout and across the entire travel process, and to implement a whole raft of new processes and measures and protocols to ensure that the industry was able to operate safely through the pandemic. And given the international nature of our business, that's not just about what the airlines do, that's about the whole travel journey chain with all the stakeholders involved in that, and getting a degree of consistency and harmonization across governments as well. From the industry side, as you see in front of you, the real bedrock of our effort was the multi-layered series of biosafety measures. We know that there isn't one single bullet to address COVID. It's a whole multi-layered approach, and that's what we've implemented, covering all the ranges of the issues from masks, as you heard from Alexandre, through cleaning and sanitization, through screening, through reducing touch points and interaction between passengers and crew, and limiting movement. So the whole suite of multi-layered measures, which those of you who have been traveling these past months will now be familiar with. And as I said, the next part of the journey has been getting harmonization through that. And for those of you that know the industry well, you'll know that the achievement that ICAO came up with in developing the Council's Aviation Recovery Task Force guidelines at the speed that they did was a major achievement. Just 3 months into the heart of the pandemic, to have globally consistent guidance is really quite astonishing. What's equally clear, though, is that as the pandemic continues on seemingly indefinitely, the work of the CART needs to continue as well. And in the past week, we've seen the second phase of the CART give its outputs with guidance on COVID-19 testing, which we'll talk about more in this presentation, public health corridors or travel bubbles, and also, very importantly, extending regulatory alleviations through to March 21. And over the weekend, we also saw CAPSCA, which is the collaboration of the aviation and the health community, releasing its manual on cross-border risk management measures and testing. And that goes into more detail on testing and risk management and gives clear guidance to governments. And IATA is developing its own guidelines to follow on from that and to give practical implementation steps. So that's a really important role being played through ICAO and CAPSCA in terms of the global harmonization. If we look at where we are now then with travel, as we said, with the multi-layered biosafety measures, the air travel environment is really very safe, and to a very large extent, the risk of onboard transmission has been mitigated. Again, as Alexandre referenced, there are some natural barriers within the airline aircraft configuration and the airflow, etc. And the multi-layered approach allows further risk mitigation on top of that. So that's the air travel environment. So the bigger issue that's left is obviously that borders remain closed. And in some ways, this is a slightly paradoxical situation, because if we look at international air travel compared to many other activities, we can see that actually for example, the airflow on an aircraft is much superior to that in many other settings that remain open, for example, classrooms or shops and supermarkets. And so that's why our call is that the air transport industry has really done an awful lot to mitigate the risk of transmission of COVID through travel. And so we're calling on governments to use testing and other measures to get borders reopened in a safe way and enable travel to resume. And the final slide before I hand over to David to talk about this from a medical perspective is that we've got 5 things that we're asking governments to do in order to open borders. And the first is very clearly not to wait. There's a lot of excitement about vaccines, and there's some good news on the horizon. But all our analysis suggests that a vaccine won't be widely available, certainly to the general public for travel purposes until at least the second half of 2021, and in some parts of the world, potentially much longer than that. The airlines simply don't have the cash reserves to last that long, and so waiting for vaccines is not an option. The second point, as I've said, the air travel environment is really very safe, and we've got health highly affected by safety measures in place, and so governments should take comfort from that. The third is that the quarantine measures that some governments have in place, government-run quarantine measures, very costly to run. And we've got extensive evidence from surveys and also from real-world travel data that they're a massive disincentive to travel. Conversely, the home isolation version of quarantine, there is significant evidence that that's actually quite ineffective in some places, with compliance rates sometimes being rather low, and that it's actually a false sense of security to governments imposing quarantine. It has all the dissuasory effects on travel and is not necessarily highly effective at cutting off transmission. Systematic testing, on the other hand, can reduce importation risk, and in many cases to very low levels. And this already in a context where international travel is safer than many other activities in a domestic setting, which have already restarted. So those are our 5 key points around safely reopening borders. And with that, I'd like to hand over to my colleague, Dr. Powell, to give more detail on testing. Thank you.
Thank you, James, and I hope you can hear me clearly here. James has touched on this already. This is really the easier part of the challenge that we've tried to meet, is the risk of in-flight transmission, and we're comfortable that this is low. 3 major pieces of evidence support that. Firstly, all of the modelling done by manufacturers and scientists about the flow of particles on board the aircraft, and we've talked to you about that somewhat in previous forums. The second is that the published case reports we've been following in great detail this year, and I think not long ago we tallied the total at 40 secondary cases, suspected or probable, during the entire pandemic. That total sits at around 50 right now, with the most recent paper that came out a few days ago. So it's occurred, but the numbers are very small, and against the backdrop of huge numbers of travellers. And the third piece is the extensive field testing done in the USA by the military there through the Transcom DARPA study. So I'm not going to dwell on that because it's in some ways the easier part of the picture, and we then move to the next question, which is the risk of importing cases. And this is the issue that James has touched on, which has led to all of the border restrictions, including quarantines in so many countries around the world. And our question for some time now has been, how can we use testing to modify that situation and to free up some of those restricted border processes? So let's just take a bit more of a look at those. And the important considerations are to some extent obvious. First of all, how effective are any tests that we consider, and we'll talk shortly about the sensitivity and specificity of tests and what they mean and how we apply that in evaluating their use at a border setting. Secondly, and very importantly, can the testing be done quickly enough to be practical in the settings that we're looking at, and in particular, can it be done in an airport, or do we need to do it differently from that? Thirdly, how are the tests administered, and is that something that's going to be acceptable for travellers? And in this regard, it's obviously much better if we can use something like saliva, which is less invasive than the deep nasopharyngeal swabs that have been so widely used. But a midway possibility is a nasal swab that goes through the front of the nose and can be done by the person themselves under supervision rather than done by a healthcare worker. And finally, of course, cost. So let's look at what's around and what's coming in terms of possible tests. We'll do that in a moment. But to begin with, this question of sensitivity, and simply put, it's better to illustrate. So if you have a test that's 99.5% sensitive, that means that only 0.5% of the negative test results actually are false negatives or missed cases. So those are the situations which allow somebody to travel who is infected, and that, of course, is the risk of introducing a new case. But with low prevalence overall, and I need to explain that, so even in the worst affected communities, at any one time currently, the number of people with COVID at any one time is just a few percent. So it is, in that sense, low prevalence compared with other screening tests where we're looking for something that's much more common than that. And so if we apply that in a real example, Italy, earlier on in the year, at the very height of the pandemic, there was a community prevalence of around 4%. And Italy, at that same time, had passenger movements totaling about 410,000 passengers per day. So a test that was 99.5% in that environment would have missed around 80 infected passengers per day in all of Italy. So that's the sort of numbers that we talk about if we have a very sensitive test. And if you actually apply that to a slightly less sensitive test, it increases, but not dramatically. The other side of the coin, though, and this is of great concern to travellers, of course, is the specificity, and this is referring to the rate of false positives. So I've used as an example here the recent study from Public Health England in Oxford, which has looked at the Innova test, antigen test, which they felt was the best of the rapid antigen tests. It's got a specificity of 99.6%, and that means that of those positive results, 0.4% will be false positives. So those are situations that will, of course, prevent somebody from travelling unless you can rapidly confirm that they're actually a false positive. And the way the statistics stack up is that, again, in a low prevalence situation, just a few percent of the population actually at risk at any one time, then in actual fact, most of the positives that you register will end up being false positives. So there's a significant number of people who travel, get a false positive, and therefore unnecessarily will have their travel disrupted. This is obviously something to avoid, but it's great, therefore, that we've got some rapid antigen tests which have got really low false positive rates, or if you like, very high specificity. So if we apply that particular test using figures from a European study that's about to be published, if we take an average sort of prevalence for Europe currently at any one time of 1.5%, look at an airport that's got 20,000 travellers going through it, then you'll get something like 680 positives, but just over half of those are in fact false positives. So this is something that has to be managed in the field with a mechanism for following up and retesting, perhaps with PCR. Now, next slide, we'll start to look at the various types of tests, but the one you're familiar with from the hundreds of millions of tests done all over the world during the course of the year is the PCR polymerase chain reaction. And it's got various extensions to that name, but they all mean essentially the same thing. And it takes a swab from the back of the nose usually. You amplify the sample to try and grow the genetic material, if you will, and then analyze that. It has excellent sensitivity and specificity. That's its strength. But the weaknesses are firstly speed. It takes hours in the best case, because that's what's required to amplify the sample. It needs a laboratory. This is a major challenge in an airport setting, of course, but in many other settings. And in some parts of the world, it can take days to get a result. Most of the testing has been done with nasopharyngeal swabs, but increasingly there are some areas who are starting to use saliva, which is obviously better. And in terms of cost, it's high. So typically over $100, and in some places much more than that, with availability problems in many locations. Let's then look at what else is around. And we've broken this up into various categories here. So on the left, you see the PCR characteristics, which we've just discussed, and it is the gold standard. But I think we talked about all of the features of that. And one thing to add there is that all of these tests will fail to detect somebody in the very early stages when they are incubating. And there's a period of time when they can potentially test negative but still pose a risk with all of these methods. The next column, the second column, grayed out there, but that's fine, is RT lamp, or what's also called isothermal PCR. And along with it, there's some other similar tests, which are, again, high efficacy, high reliability, but not the gold standards, somewhat faster and somewhat cheaper. So we've traded some accuracy in these tests for greater speed and lower cost. And they sort of represent an intermediate solution, if you will, between PCR and the highlighted category, which is the rapid antigen tests. These are what we're interested in for the aviation setting, because they're extremely fast and extremely low cost, just $5 to $10 typically, on a little card arrangement, a so-called lateral flow device, which is a bit like a pregnancy test in terms of appearance. And the sample from the usually a nasal swab is added, and quickly causes a colour change that can easily be read. The number of tests that have been improved around the world is rapidly increasing. WHO's approved some of these, And as I said, they were recently reviewed by Oxford, and the ANOVA test was found to be one of the highest scoring. We're in no way attached to any particular brand of test, but just to the concept that it may be used. And then lastly, on the last column, there's a series of emerging tests, including something called the MRA epigenetic test being researched by the US military, a number of spectroscopic tests, which potentially could involve just a breath test, and another one, more traditional mass spectrometry, which is being used in Singapore, again with breath. Some good results, but not really able to be fielded in large numbers. And you've heard about the dogs being tried in Helsinki airport, but again, it's hard to, we don't yet have good validated results for those. So these are all really in the emerging category. So in summary, we're looking principally at the PCR test on the left, the gold standard, versus the rapid antigen tests, which are fast and cheap, but obviously sacrifice some performance in the process. So next slide talks about when to test, and I think James will come back to this. The options are at the airport on departure. What does that do? It risks very last-minute cancellation for the traveller if there's a positive test, and for their companions. And it's difficult logistically because you need you create a hold-up in the departure process, occupy space in the airport, may have to have healthcare workers present. Certainly, if you were going to do this, the antigen test is the better one. But the other option is prior to departure, and many countries in the world have already applied this as their requirement for travel. The disadvantage here is that it allows a window after the time of the test for infection to occur, or for further incubation to lead to the person becoming positive. And we've certainly seen examples where that has occurred. The other challenge with those tests is it does require a way to firstly securely confirm and fraud-proof the result and communicate that, and also recognition between the countries that are receiving the passenger and the origin of their travel to make sure that the test is actually proved and recognised. And again, we've seen real challenges of that in some countries. The last option is on arrival. This perhaps is the least desirable in a sense, because it opens the window to great uncertainty as to what happens when somebody tests positive on arrival. But those are the options, and if we just move to the next slide, how do we kind of put these into practice? And the approach that's been recommended in the ICAO guidance about to be published is a risk-based one. So firstly, evaluate the risk in the two communities, destination and origin. How do you do that? You look at the infection rates, new infection rates currently per head of population. Look at also the trend in what those are doing, and very importantly, look in the background at how well the public health response is being managed. And there are some useful statistics you can look at there, particularly the test positivity rate. And then, having done that, there are a few approaches. So if travellers are going from a low prevalence to a higher prevalence country, there's really no rationale for either quarantine or testing, because the travellers represent a lower risk than the community that they're entering. Secondly, if the travel and WHO have said this publicly, if it's a similar risk and a similar strength of public health response at either end of the journey, then the travellers really have a similar risk to the community around them. If you also added a negative test, an antigen test even, then they'd be lower risk than the community around them. So the more challenging one for the public health folks is if somebody's coming from a higher prevalence environment to a lower one, can they reduce or modify or get rid of the quarantine requirements along with a program of strategic testing? And that in some cases is a combination of tests before and after the travel. And there are a number of modelling papers that have looked at how this plays out and concluded that even in the worst case, you could reduce a 14-day quarantine to a 7-day one with a careful testing program before and after travel. And if you were prepared to accept some higher risk, then you may be able to, in some cases, do away with the quarantine altogether. So, next slide. My summary then is that controlling the importation risk is challenging, but a risk-based approach can avoid quarantine in many cases, and certainly testing in association with travel can facilitate this. The technologies that we're seeing are developing rapidly, and of course testing programs are in place in many countries in association with travel. But we still have some important implementation challenges. I know James will touch on some of those in the rest of the discussion that follows. Thank you very much.
Thanks, David. So if I just following on from that excellent overview of testing and looking at sort of some of the application of that, let's start sort of picking up almost where David left off with how systematic testing can mitigate importation risk. So as David said, there's a real question mark around when's the best time to test. And all of the three options he laid out have got pros and cons. For pre-departure testing, really there are four big benefits. The first is actually what's not written here, but it's for passenger confidence and passenger certainty. And that comes through very clearly in our passenger surveys that we've seen. Also, particularly if you do the testing very at the airport or very close to the airport facility, you can create a COVID secure, a COVID clean travel environment. If you know that everybody beyond there has been tested,
James,
that's
gone mute.
Hello. Let's check. How about now?
Yeah, we can hear you.
Sorry about that. So yeah, the benefits being passenger confidence, creating the COVID secure or COVID clean environment beyond the point of testing, particularly if that's at the airport facility itself. That mitigates the importation risk for the receiving country. And a further benefit is that by doing systematic testing, which isn't what we're seeing in the community in many countries, you can also detect asymptomatic cases. So those people that slip through the net, the underreporting that we see in many countries, the difference between the reported prevalence and the true prevalence, systematic testing would pick many of those up. So actually testing through travel could in some ways be more effective than what's happening in communities. And we see cities and regions and countries now starting to take this systematic approach for exactly this reason. So just to give an example, as David tried, I think the case studies helped to bring colour and light to some quite complex ideas. a number of trials running around the world, but here's just to pick one: Air Canada and Toronto Pearson Airport, in collaboration with Master University, did a voluntary testing arrangement for arriving passengers into Canada. Those passengers still had to quarantine, which is why we were able to get good data at 7 and 14 days after arrival. 20,000 tests were carried out. They got a PCR test on arrival, and then were given 2 self-testing kits to take a test on day 7 and day 14. So the first piece of good news is that 99% of those tests which were carried out tested negative. So that's 99% of those 20,000 travellers that, if quarantine hadn't been placed, would have been able to go about their business and arrive in Canada and get on with their reasons for travel safely. And I think that's the really important message here. From a public health perspective, of the 1% of positive tests, again, good news is that 70% of those were picked up on that first test on the day of travel. 30% were picked up at day 7. So Canada, with its 14-day quarantine, actually they picked up less than 1% of the positive cases at the day 14 test. So, as David says, quantitatively, you can massively reduce the risk, even with that 7-day quarantine. But actually, the risk with no quarantine at all, with the 99% testing negative and 70% of that small number of positives being caught on the day of travel, is also very effective. Moving to the next slide. I think this again comes to present context here. Risk is relative, and certainly the WHO is very clear that there isn't a zero way out of COVID, at least in the near or medium term. So the choice that's there with governments is balancing risk against the benefits of opening borders, and also against the risks within countries, because in the vast majority of the world, there is community transmission of COVID in country, and there is a level of prevalence in the background against which we should be comparing travellers. And David gave examples of that at the end of his presentation. So, as David said, if we can reduce through testing, reduce the risk of the residual risk of an arriving passenger being infected, then I think there's a strong case to argue that those travellers should be subject to no greater restrictions than those are applied on the residents of the country in concern and within the domestic economy. I think the other reason why this is so important is we mustn't forget the huge economic benefits that air transport facilitates, and the huge impact that the pandemic has had on those, not just on the industry itself, but on those business in the industries that depend on aviation. So if we look at the most recent figures from ATAG in their Benefits Beyond Borders report, you see a reduction of more than 55% in both the jobs supported by air transport, 46 million lower than they were in 2019. And that's equivalent to a reduction in global GDP of more than $8 trillion. So again, some very important economic benefits of opening up borders in a risk-managed way. So moving on to the next slide. So I think that's where we see an important role for the rapid tests. Dave has also already gone through some of the pros and cons of those tests, but we do see a real role for rapid tests, be those antigen or some of those emerging technologies, to be used in a travel context. It's very clear that the PCR isn't suitable for being within the direct travel experience, maybe some days before or subsequent to arrival, but not within the travel environment. We certainly see the rapid tests and rapid antigen tests as the way forward. We've already talked about the fact that, other things being equal, pre-departure testing is favourable for passengers, but wherever the testing is, doing it close to the time of travel is very helpful. Moving forward to the next slide, which talks about some of the practical considerations, and these are based on lessons learned from some of the trials and pilots that are going on around the world to allow testing capacity to be deployed in an efficient way in a travel setting. First is good analysis, understanding what the expectations are, forecasting the expected level of passengers that you're going to need to test, so you're resourced accordingly. One of the things that's come out quite effectively, quite interestingly from many of the pilots is that, contrary to what you might expect, it's not actually the sampling of passengers, the taking the nasopharyngeal swab, which takes the longest time. In many cases, it's actually registering the passenger. So the more that can happen remotely before arriving at the airport environment, that can really help smooth flow. We already talked about allocating staffing resources. The corollary of the point around getting people arriving pre-registered is also, once the sample's been taken, if you can safely let them move forward and leave the sampling area and avoid that becoming a bottleneck, again, that's very helpful to flow management. If you can do that in a safe way with all the other multi-layered biosafety measures. And finally, obviously, it is important to monitor this and to have a continuous improvement, performance monitoring, and a continuous performance improvement plan as well to evolve and to improve performance over time. So it's certainly challenging to do testing in the airport environment, but not impossible, and there are already some really important lessons learned here that can make it easier and better from a passenger perspective and also for a facility management perspective. Moving forward, coming towards the end here, I think a final point, this is really important. We see certainly David and I that have been in part of many of the conversations through ICAO and the like, we see a lot of work done on the basis of modelling studies, sometimes very early on in the pandemic, and making assumptions around some of the key parameters that are relevant to how effective testing regimes may be. And that's normal and understandable, but we've now, many months into the pandemic, there's lots of trials going on and lots of pilots from which really rich data is being gathered. And so one of the things that we would really encourage governments to do, and we stand ready to work with governments to do this, is to base their policy making on real world data that is available now that wasn't several months ago, so that it really reflects what we're seeing on the ground. And even if you do use modelling studies, at least make sure that some of those input parameters are gathered from real world data. So I think it's a really important point to make sure that we really are making the best evidence-based decisions that we can do. So with that, just to, I think, really coming to the end now to conclude on the final slide, which just say again, just reiterating this really, consider the multi-layer mitigation measures in toto as a whole, as a package, rather than isolating individual ones. When looking at the risks of importation, consider that relative to the benefits that would come from reopening, and also, as I said, to in-country risk. Do use rapid tests if they're going to be part of the travel environment, and do it as close to the point of travel as possible. And use real-world data as a basis for developing standardized global approach to this. One of the things that we are seeing is a real patchwork of testing regimes, and that creates confusion for passengers, creates operational headaches for the industry, and one can only suspect that it's not as effective in mitigating the risk as a coordinated global approach would be. So with that, I think that concludes the remarks that I had. Thank you to David. And so, Tony, back to you.
Great. Thanks, James and David. And also, I should point out a special thanks to David for joining us. He's joining us from New Zealand, so it's quite in the middle of his night. So we appreciate that very much. We have a fair number of questions in the queue, so we'll get to them in order. The first question basically says, understand the approach to testing. Right now, testing's been implemented in lots of places, but that still hasn't replaced quarantines. So what do we think would be the breakthrough moment for testing to result in governments adopting policies not to quarantine? James, that's probably for you.
Yeah, thanks. I think it's a really important question. I think it's really as much around the testing technology. It's about the approach to risk. I think really we see cases where there are countries with really quite high levels of prevalence within the domestic setting, yet still travellers from potentially lower risk countries are still being asked to quarantine on arrival, or that the impact of the test on reducing risk isn't being fully taken into account. And essentially, there are governments which are applying a risk elimination strategy to international travel when it's a suppression strategy within the country. And I think there's a level of incoherence there. And what we're calling for is for I think a more nuanced approach to risk that reflects that we can do an awful lot to reduce the risk of importation, such that arriving passengers are less likely to be infected with COVID than people in the community setting. And I think that's the mindset shift which we're calling for.
Okay. But James, I think the question is, do we see any signs that mind shift is on the horizon?
I think we are seeing some signs of countries which are heading in that direction. And I think it's important that the ICAO manual on testing and cross-border risk management was published just at the weekend. So I think that it's really key. It's a key moment to see how states react to that and how they take that on board. And that's something obviously we're going to be working on in the weeks going forward. I think it's probably equally important just to restate something else that we mentioned in the at the top of the presentation. It's really important that governments don't wait for vaccines here and don't take their foot off the pedal. I think we certainly know that there are governments that are thinking about doing testing regimes to replace quarantine, and we do encourage them to continue with those plans, and of course we stand ready to work with them.
Okay, thanks, James. We have a question. Question basically says, we've talked a lot about contamination on board. This goes back to the earlier part of the presentation. But isn't the risk higher in the airport and on the way to the airport? And what are we doing about that? Maybe that's one for you, David?
Yes. The risk probably is higher through the airport and through the boarding processes as well. And they've been heavily modified in most places already. So social distancing and avoidance of touch of common surfaces is the norm through the airport, through the boarding process. But I think it's right, the very important point to consider the entire journey. from home to the airport and then through the airport and right through. But the ICAO guidance certainly covers all of those aspects and in some detail.
If I could just jump in there as well, it is one of the advantages that I mentioned with testing immediately pre-departure, pre-entry into the facility that gives it an additional degree of confidence that people entering the airport aren't infected at the time of travel. And so it's just a further layer where pre-departure testing is the route that's chosen.
Yep. And if I could add to that, we've done some public opinion polling of people who have traveled with the measures in place, and we've asked them about the whole journey. And in general, we're getting about 86% positive responses saying that people feel safe traveling with the new measures. So we do believe that what ICAO has implemented or advised and what states are implementing is having a positive effect on reassuring passengers of safety. David, we have another question for you. And this one talks about a recently published report in New Zealand talking about a flight on Emirates from Dubai to New Zealand, where it talked about multiple passengers perhaps being infected on board that flight. How does that jive with the earlier comments we made about onboard safety?
Yeah, thanks. We're given early notice of that paper, which is a very good one, actually. It doesn't change the situation overall. We've been tracking those suspected or probable in-flight transmission events all year long. When we recently did a press release, that number of secondary cases was sitting at 44, and now with that New Zealand paper, it's about 50. But of those 50, almost half occurred from two discrete events on flights back in March. And the vast majority of the 50, not including this most recent one, were in the scenario where masks were not being worn on board. So the significance of that new paper is, first of all, it's been very well done, but it's occurred with mask wear and with an index case who was not symptomatic at the time. So the risk is certainly still there, but what we presented, taken in total, still points to an extremely low risk and certainly lower than any other public indoor environment that's been studied in depth.
Okay, thanks, David. We have another question on that same study, and I think you've answered part of it, but the questioner also asks, doesn't the study point towards the need for seats to be left open on board flights so that social distancing can be maintained?
Well, the studies that have been done on airflow don't really support the concept of keeping the empty seats. And in fact, the two events that I referred to where there's been multiple people infected on board, the sort of super spread events, if you will, would not have actually been significantly helped by that sort of distancing. So in keeping with the rest of the pandemic, where it's a small number of initial cases that have really propelled the pandemic, so they say that 20% of cases are responsible for 80% of the outbreak. In the same way, within our environment in aviation, those very unusual events are responsible for a large number of the cases. And even in that most recent New Zealand study, if you look at the actual seating pattern where the infected cases were, every second empty seat probably wouldn't have altered the outcome there. And we don't know where the contact occurred. It's important to point that out. It could have been during boarding. It could have been during the transit stop that they all had. or it could have been through bathrooms. So all of those are plausible, and there's no way to know.
Great, thank you, David. We have now a couple of questions about vaccines. And today, Qantas announced some policies with respect to vaccination for travelers. And the questions, several questions, but let's take them one at a time. One question essentially asks, will the Qantas position become an industry standard? And what issues would that throw up? So maybe, Jane, did you want to start with that?
Yeah, okay. Thanks, Tony. So I think the first thing to say is that as we've been saying with testing and as we've been saying with the onboard mitigation measures, a global standard is going to be critically important around treatment of the vaccine. I think in terms of what it means around reopening borders, just go back to what I've been saying before. We don't think that governments can wait for there to be a vaccine before they think about reopening borders. And our expectation is that it's going to be some considerable time before a vaccine is widely available for the general population. And again, David might want to jump in, but our expectation is that there's going to be a pretty strict rank prioritization of who gets the vaccine. And that early on, it's going to be healthcare workers, vulnerable groups such as the elderly, and so on and so forth. And it's going to be some considerable time before there's widely available access to the rest of the general population, such that a traveller could easily get themselves vaccinated if they needed to make a trip. And so I think that's why we are very clear at this point that it's not necessarily quite the time to make that step, and that there's still going to be an important role for testing. So I think I'll pause there and see if David's got anything to add, actually.
It's a really interesting question. In fact, James and I were discussing it only a few hours ago as to whether this will become widespread in communities like Australia, where the prevalence is low, and it's a really strong possibility. I think the concept has already been perhaps explored with so-called COVID-free flights in Europe, where everyone gets tested that's going on a particular flight, and if they're not prepared to get tested or can't do so, then they get transferred to a different flight. And you can kind of imagine that concept could move to those vaccinated. But of course, this can only happen when the vaccine's widely available, as James says. Thanks.
And we have another question that sort of takes us a step further and says probably vaccines will take a while. Testing might be implemented before that. Do you see, or how do you see managing a system where you have those two options? What kind of standards or what kind of framework would we need in that situation?
It's going to be it's a really good question, and it's certainly going to be a challenge, and it's one we need to get our arms around pretty quickly. I think something's going to be really important to it, and I know it's on the agenda for later in this session, is the health credentials aspect of it, and being able, whether it be testing, whether it be vaccination, is being able to have verifiable information about the health status of passengers. And I think that is going to be critical to navigating through that period.
Okay, great. Thanks, James. Getting back to testing, we have a few more questions. One questioner asks, what happens if someone is tested false positive? Who would pay for that potentially stranded passenger, and how would they eventually be able to continue their onward journey?
Yeah, that's one of the great disadvantages of testing on arrival, of course, is that scenario could occur. But if somebody tests before they leave home, far less of a problem. Of course, if you do a screening test and it's positive, you don't know whether it's a false positive yet. So you actually have to go to the next step of doing a confirmatory test of some sort. And again, it's a reason why we would be interested in exploring some of the lower cost confirmatory tests. That was the second column, including RT LAMP and so on, that might be able to be done quickly enough that the person could still travel. But it'll be local rules that apply in terms of payment if you are testing positive at destination.
Okay, James, did you have anything to add?
Yeah, just to say to that. Now, I think David talked to the confirmatory protocols, and in my mind, it's something like the secondary screening that you can have if traveling to the US with the security, where a proportion of people have that secondary screening, that the testing could possibly work in that way. But I think also to the question around onward travel for the stranded passenger and so on, this is something that we've seen throughout the pandemic. Airlines wanting passengers to be able to book with confidence and offering really unprecedented levels of flexibility to passengers should their plans change for whatever reason, and this being one, to do so. And I think that is the airlines want their customers to be able to continue with their journey at such point as they're cleared to travel, and offer the flexibility to do that.
Okay, great. Thanks, James. We have a question going back to the idea of vaccines. And the questioner asks, basically, what will happen, or what do we anticipate will happen the day after a vaccine becomes available? So I suppose the question really is, do we see that as being a big driver of demand? Maybe I can start with that. We have done some public opinion polling to understand triggers for people to return to travel, and we've seen three things: vaccine, test, and treatment. So clearly, if a vaccine does become widely available, that if the results of our polling are correct, that should lead to a bump in demand. But David, you were going to say something?
Something similar, Tony, but of course the day after the vaccine comes out, nothing will happen because it'll take months to get sufficient penetration and distribution.
All I would say to add to that is that the real trigger here is border restrictions. I think we've seen lots of evidence that where the quarantines have been removed, there are large spikes in booking behaviour, and so provided that the quarantine, the measures that are conditional for quarantine to be removed and borders to reopen are widely enough accessible to the population, we see significant latent demand of people wanting to travel, and so I would certainly expect that to be the case, as long as whatever measure isn't an artificial barrier. Sorry. Yeah.